I am extremely grateful to Dr. Puva, Dr. Meno, and also Dr. Banshi for inviting me to give this lecture. And this is really a fantastic meeting, particularly the focus on solutions. I think we have a lot of problems, but I think we have to try and try out solutions in order to learn as we go along. And just looking at the titles of this symposium, you really could see the creativity, the knowledge, and also the wisdom among the faculty members and also the organizing committees, a very, very holistic view at looking at the problem. So I've been given the task to talk about digital registers and data-driven care tools. So first, I would like to welcome you all to Hong Kong, also a very vibrant city of 7 million people at the southern part of China, and also now rejuvenating itself against, the rapid economic development in Greater China, which is also establishing great ties with India. And I think these two giant countries are going to transform the world in all fronts. So these are my disclosure. And I just thought I will start with the story. I think these stories that I'm sure many of you have seen, particularly in developing economies. So when I first came back to Hong Kong from UK more than 30 years ago, Hong Kong was just at the beginning of its economic development. And these are many success stories that I've seen. So it's just when I was a junior faculty member, it was one of those evenings that I admitted a 45-year-old lady with shortness of breath. And of course, when you look at the chest X-ray, she's in heart failure and she's got retinopathy and she's actually in renal failure. And really going back to the history, we all taught to do good history taking. So in fact, this was when she was 22, she married a gentleman from Hong Kong, and she was actually living in China. At that time, it was very common to have marriages between Hong Kong men and also women in mainland China. She gave her the birth of her first child at the age of 25, and then she moved to Hong Kong at 28, and the affluence of Hong Kong given her improvement in life, but also given her a lot of issues. She put on a lot of weight. And then at the age of 30, she had the second pregnancy, and she was found to have gestational diabetes, despite having universal healthcare coverage, and that she was advised to have OGTT after, the pregnancy. She did not. And of course, she already had diabetes for over 10 years when then she first presented, really to the healthcare system with this awful carbuncles over this on the back, and I still remember very distinctly. And when you went through the nose, of course, her glycemic control was very poor. She was really episodic in terms of care. She was asked to have insulin. She refused. And of course, now she had everything affected. And so here, during her 20 years of life, she missed many, many opportunities. And I think really these are some of the motivating force that help us or that drive us to make some changes and try and develop solutions. So not only people in the lower socioeconomic class are affected, so these are, diabetes affect all young and old, rich and poor, and also all ethnic groups. And here, these are a pair of twin sisters that I see. So if you've seen the film, right, Sliding Door, you would know what I mean, the message. So both sisters, right, both twin sisters, they were highly educated. They were not obese. They were very lean. They have a very healthy life. Both of them had gestational diabetes at the age of 30. Both of them developed diabetes at the age of 35, but both of them, particularly the one in Hong Kong, would not actually go and see the doctors because she doesn't really think why she should have diabetes. There's a lot of, rejection. But she was surrounded by some very caring family members who were actually managed by a private diabetes center that also, helped set up with the university. And I went there once or twice a month. And so she was persuaded by the family members to come and see us. And it took her 2 or 3 years to finally agree to have regular follow-up. And ultimately, she was put on all the right drugs. She's on insulin. And now she's in her 60s. She has no complications whatsoever. But sadly, her sister, who actually lived in the United States, and she did not have a lot of family support, and her care was, we're not quite sure, but she's been asked to put on insulin, but again, she won't go on it. And finally, at the age of 50, she died of end-stage kidney disease and also stroke. So these two sisters, they share the same set of genes, but they live in different places, they have different care standard, and the outcome is totally different. So this is really the premise of diabetes as I see it. Really is diabetes a very heterogeneous condition with multiple causes, trajectories, and outcome. And really our job is to redefine, right, to unravel this heterogeneity in order to individualize, personalize care with precision and value. We all are born with a set of DNA from our parents, and really that also put us on slightly different starting points. And depending on perinatal exposure, our childhood, our adulthood, etc., then, these would, your education level, your exposure, your work life, etc., your social habit would, depending on your age and also your ethnicity and your sex, you will develop diabetes at different age of diagnosis. The key point is only 1 in 3 people would develop diabetes at the age of, when the lifetime risk of diabetes 1 in 3. Even people who are overweight or obese, about 1 in 3 of them develop diabetes. So there is some predisposition for individual, and we have to find them. There are people who are obese and, so are obese or overweight or high age, they do not have diabetes. There are lean people who are young who have diabetes. But ultimately, these complex causes will actually give rise to these 4 major risk factors: glucose, obesity, blood pressure, lipids. If we can sort it out, we can sort out a lot. However, the complex interactions among these 4 risk factors will create a very abnormal internal milieu that would damage every single blood vessels and nerves. And this will give, and this can be seen, okay, from the retinopathy and the albuminuria. These are really the surrogates of the outcomes. And these are all the cardiovascular, renal disease, heart failure, and as we get better control of blood pressure and lipid, we are now seeing more cancer and also, frailty, dementia, etc. And this gives rise to all the comorbidities, hospitalization, and premature death. Over 20, 30 years as we've seen it. However, if this person have access to care, medications, education, and support, this would not happen. So my talk is about registers, okay? So I just thought, I'll search the PubMed and see, what is the publications on registers. And you could see that really between 1969 and 2025, the number of publications of registers has grown. And I think, our group is also part of that journey. So really one of the first field papers on register is published by Weddell in 1973. And here there's a little bit of a clarification. Registers is the database. Registries is where you keep the database. So strictly speaking, it should be register. So the principle, of setting register is actually collate information from a defined groups over time, which may be used in the prevention or treatment of disease, the provision of aftercare, the monitoring of changing patterns of disease and medical care, and the evaluation of planning of service. So this is the purpose of a register. And, in 1993, the St. Vincent's Declaration of the IDF, suggested that we need to have diabetes centers, we need to have diabetes register and diabetes team in order to provide, good care to people with diabetes. And I happened to be on board at that time, so we set up the diabetes register in 1995. After 5 years, it was adopted by the whole hospital authority that look after all the hospitals and clinics in Hong Kong, become the territory-wide risk assessment and management program. In 2007, we received a major educational grant and we digitized this Hong Kong Diabetes Register protocol. And then at that time, we also developed risk equations to visualize the data. And with the help of a lot of our collaborators from Asia, we have the JADE register. So I want to highlight that we learned a lot from these registers. And really, we are not just talking about medical issues, we are talking about a societal and mental issue. So these are really just some of the papers that we have published. So among all the biomarkers, I'm sure you agree that albuminuria is the most important biomarker. It really is the composite, of all the end products, all the consequences of those 4 risk factors we talked about. And these urine albuminuria and eGFR are highly predictive of all-cause death and cardiovascular renal endpoint. Your education is very, very important. Again, with this register, we have very, very careful documentation of all the covariables. And after we have adjusted for all the variables, your years of education is independent predictor of death. Using the register, we're also able to document, the percentage of people with depression using PHQ-9. About 10% of people have depression. And again, these people are more likely to die. So therefore, diabetes is really, have many faces, and we need to sort them out. And here I want to highlight again that register is not the same as electronic medical record system. A register is well designed, implemented, and kept. It has an impact and it has a purpose. We're trying to combine practice and data analytics to drive actions. So in most of the administrative databases, you have age and sex, but a lot of those key parameters, which are the exposures, are not actually systematically collected unless you have a register design incorporated into the EMR. Most of the EMR might have lab result, might have drugs, and also ICD codes. But having a good register, with all the variables, then you can link it to register, and that become a very powerful tool. Now, of course, we now have a lot of risk equations, risk prediction tools for CKD and CVD, but are we really seeing the big picture? And I think we are not just talking about CKD and CVD, as I already pointed out earlier on. Diabetes is really a digital condition, right? And health literacy and numerical literacy is absolutely essential. These are the numbers that we're dealing with. They all have prognostic significance, and they all inform medical decisions. So if we don't measure it, if we don't monitor it, we can't manage the patients. Likewise, this kind of combination of digits different kind of permutation and combination would define that person's risk profile and his future fate. And we need to use that information to educate, engage, and empower the individuals. Many of you will have seen this figure, the ADASD, but again, emphasizing the importance of those 4 risk factors. But I particularly want to highlight the inner 2 circles. Very few people talk about it, but I think that is really what we have signed up to do. The goal of diabetes management is, of course, prevent complication, preserve quality of life. And the principles are surveillance of complication and screening of risk factors with monitoring and ongoing review. To avoid therapeutic inertia, we need to understand the underlying physiology in order to individualize treatment, reduce the risk of hypoglycemia. We need to have some structured education and support in order to modify behavior, to provide psychosocial support, taking into consideration social determinant of health, and with shared decision-making using the right kind of language. And of course, that would call for an organization of your practice in order to deliver care, and that also has to take local context into consideration. So there's a lot of talk about CGM in this meeting, and I want to highlight that we also need to align the needs of the patients and providers in order to bring out the best of technologies that include not just CGM and drugs, etc. Now, I think when a person who have lost the sensing, once they lose the incredible balance mechanism of sensing glucose and secreting insulin in a very well coordinated manner, then it's just like the thermostat actually become dysfunctional. And here, anything this person do, the eating, the exercise, the sleep, the emotion, the alcohol and the smoking, the medication, the sick day, the body weight will all affect the blood sugar. And of course, here, in the CGM, we are capturing all this information, but have we captured all the other information in order to make good sense out of it? That is a question that we need to really think about, because I think, we really need to have good data in order to have good AI model. Otherwise, it's rubbish in, rubbish out. Very, very important. And that is really how we physicians become critically important to help and gather those information in order to make these AI models that are valid. And there are some papers showing that clinicians also experience barriers and also need for CGM implementation. They need patient education material. They want to have some CGM samples of devices to show the patient. But most importantly, they need somebody to help them to, practice to help and educate individuals. And of course, if we can integrate the CGM into the HR, that would be good. That was a very interesting paper, and that is really looking at the health literacy of people using CGM. And essentially, they were, testing the health literacy score and also the numeracy score of these individuals, a very broad representation, multiple ethnic groups, both type 1 and type 2 diabetes and different ages. And you could see that really the number is not very good. Most of the score is actually below the median number. Now, interestingly, actually, the CGM is initiated by, in 50% of the patients by the doctors, and about only 48% of these people were actually given education. And even among those people who were given education, 10% of them thought that it did not actually address their needs. So, food for thought. Here, I think all of you know about this KDIGO heat map. Does it mean anything to these people? The albuminuria and the EGFR are very powerful. With that, you have 15 risk categories, and they are all predictive outcome, and they are, our treatment guideline. However, when you actually look at the real-world data, albuminuria is one of those parameters that are not actually being measured. And it makes you think, why is it difficult to measure an albuminuria? Every one of us in this room would know it is difficult, right? Given that you only got 5 minutes to look at the patient. So this is just the enhanced data showing that 1 in 3 people with diabetes, hypertension, or diabetes only have urinary albumin test, and of these, 1/3 of them will have albuminuria. And so a lot of albuminuria and CKD are actually being missed out. So when you see a patient, I wonder what are the questions that go through your mind. And these are certainly the ones that have been sort of on my mind over these 30 years or so. When I see a patient, who is this patient? Who is his or her problem? Do I know what he wants or what he needs? What is his long-term risk? And how can I mitigate that risk? Because we are not interventionists, we are doing prevention. So we are managing risk. Does this patient really know how to manage him or herself for the rest of her life? Will I know whether he or she would come back to the clinic later on? Will I know what happens to him or her in 5 years? Do I know how well I have performed? And how can I demonstrate that my diagnosis and care is actually making a difference to this individual? And how can I ensure the quality of care of this patient when this person might be seeing different people and also may not be coming back? As a care provider, can I tell my payers that I am providing value-based care? That means prevent complications and good quality of life. As a researcher or KOL, can I learn from this data relevant to the population and context to create impact? Those are the motivations behind the register that we actually set up in 1995, more than 35 years ago. We all know that, we are basically the clinic doesn't work. It's just so busy. And you have to change the setting in order to implement integrated assessment and management in order to create a register. And most importantly, those data will have to be fed back to the providers as well as the patient in order to overcome clinical inertia and to motivate self-management. And so we don't need really huge resources. We need a small room. And that is exactly how we started. Just a small room with some office equipment, just simple tools, a fundus camera, not a fundus, really just a fundoscopy, and then also, tuning fork and monofilament. But it was all about organization. I get assisted from a very good nurse and then also a clerk. And that's it. That is the beginning of the register. Because we doctors can diagnose, we can prescribe, and then we can also make decisions. But we need some paramedics to help and gather that information to help us evaluate the patients, to engage and also empower the individual. That's the beginning of the register, aim for quality assurance, risk stratification, personalized care, and patient empowerment. If your setting allowed, that can be linked to an EHR where we can benchmark performance, identify care gaps, and also evaluate the effectiveness of the care model and also track outcome. And very simple, we just want to make sure that we attain those 4 targets, A1C, blood pressure, lipid, and also the use of organ protective drugs, for which we have many, but many of you know that many of these patients are not started on it. Even if you start them on it, they are not taking it or they are not adhering it and they are prematurely discuring it. So, starting somebody on the drug means a lot of follow-up actions. And of course, with that, need to have the assessment and also, to monitor these individuals in order to achieve those outcomes. And indeed, since 1995, that is really how we set up the Hong Kong Diabetes Register. So basically, it's all scheduled. And so now all 5 days, we will have complication screening, of course, the data enter, And then at the same time, in the afternoon, we will be able to give the report back to the patients. And that is the beginning of a series of actions. You know that this patient needs insulin, you need that these patients need CGM, and some of the special needs patients, such as type 1 diabetes, the young onset diabetes, the CKD patients, as well as the weight management programs. And this is really a very, very good setting to help and train up the patients, train up not just the patient, but the care providers. And this is really how we build up our nurses and also our data scientists and also our patients. But of course, the data is really the basis for all these risk equations. And because of the comprehensiveness of the data, these risk equations are very predictive, nearly 75 to 95% accuracy. And you could see that these are different combinations of risk factors would then give rise to different outcome. And here you could see that EGFR and ACR are really very important. When we started doing this register, immediately it became clear that there are inter-ethnic differences. Of course, the UKPDS is really the gold standard at that time, but then we found that, the UKPDS risk equations overestimates the risk. And you could see that actually the Hong Kong Diabetes Register, they predict the risk very well, well within the 95% confidence interval of the observed rate. A lot of these risk equations also do not take into consideration previous events, for example, but of course your previous events is also a very important risk factors. And in this particular risk equation for stroke, age, A1C, albuminuria, and history of CHD really predicts stroke very well with more than 85% accuracy. So 5 years later on, government actually decided to adopt the whole model, and to their credit, they really train a lot of diabetes nurses, set up diabetes centers, and they only do 4 things: structured assessment, education, relay between the doctors and the patient, and also providing peer support. And here you could see really over that 13 years, more than 330,000 patients were screened, and progressively you could see how A1C, LDL cholesterol, systolic blood pressure came down, and this was translated to really marked reduction, 50 to 70% reduction in cardiovascular disease, stroke, heart failure, all the acute complications, and even death rates. However, and this is also where we can review unmet needs. So in this extensive database, including 0.8 million people with diabetes now captured in the territory-wide electronic medical record system, with the diabetes register protocol built in, the patients with the young onset diabetic patients, these are 1 in 5 people diagnosed before the age of 40. They remain to have 5 to 8%, 8-fold increased risk of death compared to their non-diabetic counterparts. So there's a decline, but not so much in the young people. And likewise, when you look at the A1C, these are people with poor A1C control. Over time, A1C improved, but again, less so in these young people. So in 2007, we were able to incorporate, this Hong Kong Diabetes Register together with the risk equations. And here you could see the portal enabling people to perform a structured assessment. You don't have to do it all the time, probably at diagnosis 1 year later and maybe every 2 years. And really, when you think about 40 years of life with diabetes, only 20 assessments, they really can save your life. Then you could actually use a very simple, how do you visualize the data, such a complex piece of information to really let people know, that they belong to the high risk, low risk, medium risk. And most importantly, these 4 major risk factors, are they on target? How far away from target, and what is the trend? And of course, also the 5-year probability of risk. And I'm so grateful to all my Indian friends. And together we have really collaborated over a long period of time to gather these data from a broad range of settings. And with the support of 300 healthcare providers, we gathered about 120,000 patients, from 8 countries, 11 countries. And here we were able to replicate a lot of findings. Here you could see that 1 in 5 people in Asia were diagnosed before the age of 40. 1 in 3 of them were actually chronic kidney disease. And together we were able to show systematically, how compared to just a simple assessment, the issue of a personalized report together with education, we can, a doctor-nurse team, we can make increase the risk factor control and also reduce risk of death and also complications. once we got this register, we were really able to start doing a lot of work. So this was really just one of those studies supported by EASD and other foundations, and then really documented that percent of people have depression, and these people have very poor A1C control and also a high risk of hypoglycemia, probably because of poor adherence. And using this register platform, we're also able to do randomized trial, and this is one of the trials that I really like, where we actually randomized 660,000 people with diabetes. They all undergo the JADE assessment. 1 year later, they all improve in ABC, literacy, etc. But we found that actually those 300 people who were randomized to receive peer support were less likely to be hospitalized, and those people who have got diabetes distress were more likely to be hospitalized. And so that means that people with diabetes distress and no peer support, they are the ones who are more likely to be hospitalized. So these kind of, pragmatic trials are very revealing. So in Hong Kong, we have a dual track system. We have public care, we have private care. So private care, maybe they don't have all the sort of support. So as a university, we set up a non-profit risk assessment center, and basically the nurses would actually provide the JADE assessment, personalized reporting, and then with an annual reminder, telephone reminder, we were able to show, that compared to the usual care, this kind of joint care between the private sector and also the academia, with these quality assurance initiatives, we can prevent cardiovascular disease, cancer, and all the outcome by 50%. And indeed, throughout those 30 years or so, I think these data, a very, very rich data resource in Hong Kong, have driven a lot of, actions, raised a lot of political awareness. And you could see that over the 16 years. The good thing is actually we should not always look at the bad things. In those places that have, in these 16 high-income countries that have nationwide data, the diabetes-related death rate has come down. But Hong Kong has one of the highest decrements. The death rate has fallen from 3% per year to 1.3% per year, which is a 70% drop. And this is also mirrored by really a lot of the Asian countries are having that kind of improvement. So if you are a researcher, right, these databases are not only here to improve care, but they also are knowledge discovery. And we have a biobank that goes with it. And here we were able to really discover a lot of genetic variants which are particularly relevant to Asia. For example, like PAX4, this is first reported by our group, and this is only found in Asians. And this is very important for young onset diabetes. And also, we will be able to measure a lot of anti-GAD and also C-peptide, and this really helps us to redefine and polygenic risk score to really understand the heterogeneity of diabetes, particularly in young onset diabetes. And this will actually also spark off with, currently we are doing several large-scale programs, which is the precision prevention and also diabetes care, particularly in young people. So, the importance, this is really just from register, it's now become outcome models. So using this 30 years of data, we were able to really build a model to predict lifetime risk of 10 major endpoints: cardiovascular disease, kidney disease, end-stage kidney disease, severe hypoglycemia, cancer, and all-cause death. Very powerful data, and also with validation. And that predictions, over a lifetime concord very well with the observed rates. And so here, by using some simple parameters, you could see that, we can actually predict the 10 events over 15 years of this individual, for example, a smoker, a middle-aged man with some of those typical risk factors, but we can start manipulating these risk factors and then also, tell them what are the likelihood in terms of these events. But very importantly, these sorts of databases and models are very important for economic evaluation of technology and strategies. And this is really all we are currently we are doing, because a lot of the clinical trial only stop for a few years, but you can use this kind of models to really work out the lifetime benefit of this treatment. Again, using these databases, we can do a lot of propensity score matching because they are very well documented in terms of this exposure. And I just really want to highlight, for example, this paper, this I like very much. The majority of our patients are still treated with metformin and sulfonylurea, but here, the introduction of DPP-4 inhibitors in people within 2 years of diagnosis or before the A1C went up to more than 7.5%, we will markedly reduce the glycemic variability. Here you could see that the A1C variability is markedly reduced, and this is a major predictor for outcomes. And those people who have actually started early intensified treatment, you do it early, and then also with reduced A1C variability is really associated with a lot of reduction with all endpoints, including death and also, severe hypoglycemia and all the CV renal outcome. So, treating patients early, identifying them early, and then treating them properly really, really make a difference. So really, in my last few minutes, I just want to end up about this call, this suggestion that we should be using register to conduct randomized clinical trials. We all know that we all done clinical trials. We know the importance of recruiting patients. And also, when you recruit patients, you need inclusion-exclusion criteria. And that's really how all these registers become very, very useful for you to sort out patients very quickly. You need to randomize them, you need to record them, you need to retain them. And so in order to do a register-based randomized clinical trials, quality data collection is very important, and also with all the quality assurance procedures, and this together with the register and together with the stakeholders, the sponsor, the clinicians, and also the statisticians will be able to efficiently, randomize people into different kind of intervention. For example, parallel arm, crossover, cluster randomized trials in order to, evaluate outcome in a real-world setting. And this is really where, we have also done this JADE-assisted team-based care to confirm, really more than 2,000 people, the benefits of register together with a team-based care on achievement outcome. So ladies and gentlemen, I would like to finish off by really highlighting that establishing a high-quality register, by combining practice and research will drive actions. Register is a very powerful training tool to build administrative care and research capacity, especially physicians, scientists. Change of setting and team deployment overcomes the barriers for structured assessment regarding the eye, the blood, and the feet and the urine. And performing OGTT is very, very important to identify high-risk individuals for prevention. Structured multi-system assessment would engage the patients and those at risk and help improve health literacy. The proven impacts of Hong Kong DR has really improved change policy and improved the outcome in people with diabetes in Hong Kong. The JADE platform has very good cybersecurity, data de-identification. It will also overcome concern about data transfer, confidentiality, and system interoperability. Register-based clinical trials will enable implementation of multi-center study by a doctor nurse team and make gathering data more affordable and sustainable. And depending on the setting, the establishment of biobanks combined with high-quality register will close the data gap in precision medicine for the global south. Thank you very much indeed.